Alright, so to do the subtalar joint mobilization, what we're going to do is have the patient sideline with their with the treated leg on top and the unaffected leg bent with their knee at about a 90-degree angle. Alright, so to start off doing this treatment, the first thing we need to do is find out what our direction of force needs to be. So to do this, the first thing we need to do is find the subtalar tali. To do that, we find the medial malleolus, and we drop off inferiorly about 2 centimeters until we feel a ridge, and that'll indicate that we're on the subtalar tali. Also, while we're doing this test, we need to make sure that the patient's foot is hanging just off the table. Next, we need to find the sinus tarsi, which is found by, it's a tunnel that's just supero-anterior to the calcaneus and just inferior to the talus. So we're going to get on the patient's lateral malleolus, move inferior until we again fill that tunnel. So now that we have our axis, we can see that the axis going from the subtalar tali to the sinus tarsi goes posterolateral and anteromedial. So this means our direction of mobilization needs to be posteromedial and anterolateral. So to do the mobilization, we'll go ahead and stabilize the patient's talus. Just superior to the calcaneus. And again, we're moving the patient posteromedially and anterolaterally. We're also going to be stabilizing the patient's forefoot by placing their toes right into our thigh. We're going to be using our right hand to stabilize the talus and our left hand to move posteromedially and anterolaterally. How we doing? Okay, all right. So this treatment would be indicated to treat a deficit in inversion or eversion. Whether or not you're treating inversion or eversion doesn't change you moving both ways, posteromedial and anterolateral. You need to do the mobilization in both directions for inversion or eversion due to the biconcave nature of the joint. So it has concave-convex relationship and a convex-concave relationship. So if we were treating a deficit in inversion, we would need to do still do the posteromedial mobilization and the anterolateral mobilization. Indications for progressing this treatment would be the patient has achieved a inversion range of motion, sticking with our inversion example. An inversion range of motion that is no longer causing pathologies. Things to progress it to would include or would be dependent on what the patient's goal was. But say it was achieving greater inversion for dorsiflexion. It would involve progressing to gait training.